Colin Coxall, welcome to the Tokyo Living Podcast.
Hello, Sam. It's great to be back. Thanks for inviting me back.
Yes, it's great to have you back. I think this is your fourth time on the show now, fourth or fifth. But it has been a while since we've had you on.
Yeah, it has. It has been a while. Yeah. I was wondering if you'd have me back, Sam.
Yes. We had some other great guests on in the meantime. And just
did.
I
heard
back around to you.
Yeah. That's some fabulous guests.
It's been great. We're doing Mental Health Month on the podcast. This Saturday, the 10th of September, is World Suicide Prevention Day. And I think October 10th, which I believe is a Monday, is World Mental Health Awareness Day. And so I thought that would be good in that sort of month between those two awareness raising days to have a specific focus on mental health within the podcast. And obviously you've been someone that we've had on and has shared some really great information and advice around mental health. I thought you'd be the perfect person to kick off this Mental Health Month.
Great. Thank you, Sam.
So today we're going to be talking a little bit about depression. So obviously, depression and anxiety are the two most common mental health conditions, and the most widely known conditions. And it would be good to get your perspective on depression as a condition, what it is, and how perhaps from a cognitive behavioural therapy lens, you go about managing individuals who are suffering depression. Perhaps if we can just start with a bit of a definition. How is depression commonly defined, and how do you sort of define it in the way that you practice?
That's a great question. By the way, do you know what the most common mental health condition is? I know. I'm not being Socratic. Do you know?
I don't know.
Insomnia.
Right.
Which is one of the things that you look out for with depression. There are several factors. Usually, when I work with depression, what I usually do is I usually do a screener for it. Actually, I give out a questionnaire, and the questionnaire I use a very simple one because it only takes a couple of minutes to complete, and you can find it online very easily, and it's free to use, which is another reason why I use it. It's called the PHQ-9. It's the Patient Health Questionnaire. 9 questions. They're basically all of the criteria for depression, I think, which is used in the World Health Organization, ICD-11. It was developed in 1999, but it's still pretty sound. And the reliability of the PHQ is quite good. It covers the main areas of depression, which are, you go through, so little interest or pleasure in doing things, feeling down, hopeless is really one to look out for with depression, particularly the severe end. Falling asleep, sleeping too much, energy levels, having little energy, poor appetite or overeating, feeling bad about yourself, the idea of feeling like a failure, trouble concentrating on things like newspapers or TV. Your movement might be slowed down so that you notice, or a lot more fidgety. And of course, there are thoughts of the question is, thoughts you'd be better off dead or hurting yourself in some way. And often in depression, people have those thoughts. There's often not plans or intention, but it would never ever be afraid to ask about that question. Asking more about that to keep people safe, really. So that's what I would use, the PHQ-9. And there's actually lots of different types of depression. This one really is referring to, I think, what we generally talk about with depression, which is called major depressive disorder. But there's lots of different types. The other ones are, some people have it for a really long time, persistent depression. There's some people that experience bipolar depression, seasonal depression, seasonal affective disorder, postpartum, peripartum, when you have a baby. Men are affected by that, obviously less than women, but men can be affected by that as well. And premenstrual dysphoric disorder, which is PMDD, which is actually underdiagnosed. People don't tend to talk about that or look out for that. And then, of course, there are some situational depression, events that happen in people's lives. So to diagnose depression, just major depressive disorder, there are over 200 ways to diagnose depression. I think 227 to be precise. So, it is very, very common, and that's why I use the questionnaire. And there are sort of ranges, within that, which indicate if we need to address that in kind of specific areas as well. And also keeping people safe is very important.
Yeah.
Within that.
Yes, that's great. In terms of, so those 220 diagnostics, is that all sort of subjective measures? What other, so I'm assuming a lot of it's sort of questionnaire based and subjective measures like that. What other tools are used or assessment measures are used to diagnose depression? And I guess the other question was, and in terms of major depressive disorder, you talked about diagnosis before and underdiagnosis. Do we have any statistics on what we presume is sort of diagnosis rates amongst those that are actually suffering? And also time to diagnosis from a musculoskeletal point of view. We know certain conditions have a very long time to diagnosis. People sort of put up with the symptoms, or they come on slowly, or they're not really acknowledged as an actual condition or something that interferes with function for a certain amount of time. And it's very common that someone will walk through my door and say, I've had this pain for 6 months or 12 months, and that's how long it sort of takes for that diagnostic label to be applied. Do you know sort of roughly how that applies to depression?
Yeah, I mean, the PHQ-9 talks about the last 2 weeks to screen depression, but it could have, been around for a lot longer than that, and for years, possibly, simmering away. And sometimes people have several episodes of depression. People can get very good at getting depressed. There is this idea that we need to dive into every thought and sort of challenge things, and so people can kind of get very easily drawn into kind of rumination and overthinking things. And actually sometimes, and this is really a much newer development in the treatment of depression, which is more the kind of mindfulness based cognitive therapy approach, which is really about deciding whether you actually need to dive into the thoughts, or whether it's really worth your time of day. Sometimes you've just got to glide over them and say, what, it is what it is, and there's some very good material on that, in particular Mark Williams' material, or his website Headspace, or Calm, are very good resources. It's about sort of detaching yourself a little bit from the thoughts that would just sort of drag you into sort of rumination and depression, and now what's the point? So people can get very good at becoming depressed. So it's really hard to say what the numbers are, but people talk about it being the common cold of the mental health landscape. It's hard to say what a lifetime prevalence, or how many people have it now, and some 1 in 4. It depends where you look, Sam. It's very, very common. It's hard to put a number on it, really. Yeah, but of course I see a lot of it in my work. A lot of people haven't recognized it, and they come along, they're surprised that it's depression. Sometimes it comes along with other things as well, like anxiety and different things, insomnia sometimes. So, it's hard to put a figure on that.
Yeah.
But it's common, very common.
Very common.
Yeah.
And what causes it? What you've gone over a lot of different types, and within that, you can understand some potential causes, but what actually causes someone to have that low mood, to have those feelings of depression?
Yeah, good. That's a great question. I wish I had an answer to that. I mean, it is a mixture of things. Sometimes it's very clear, sometimes it's situational. Loss, for example, losing someone or losing a job. But loss is usually a big in depression. But there are lots of different factors. The way we think about things. Our biases. The all or nothing thinking. For example, it's no kind of, in middle ground. For example, you jump into conclusions about things. Mind reading, catastrophizing things. So they're all kind of heuristic ways that we think about the world, but in they can be unhelpful, and they can bring our mood down, and they can, if we're overthinking stuff, worrying a lot about stuff, our brain uses 20% of our energy, so it's quite easy to become fatigued, and it's quite easy for our concentration to be impaired as well. So I would say the way we think about things, and then we might withdraw from things. So it's then what we do. We might withdraw from activities, and life becomes less rewarding. Our emotions are impacted. We might feel sadder, guilty for not going out and hanging out with friends, and that just might lead us to withdraw and ruminate more. And then there are unintended consequences. So I don't bother returning my friends' calls, and then they don't call me, and I say, well, why nobody ever calls? Well, that's not true. Okay, it's because I haven't returned my friends' calls. But that's kind of how we can get stuck in depression. So our activity reduces, get a more negative view of ourselves. It's harder to cope with things. We don't see things in terms of making decisions and problem solving. We tend to ruminate on stuff, and then all leads to that sort of hopelessness. Really, it's that sort of what's the point? Loss of pleasure, loss of achievement, loss of purpose. Not engaging in the world, not just reduced activity, but sometimes how we engage with it, and it all kind of contributes to a depressed mood. And then if you feel trapped in that, it can get quite severe, and for some people it can be dangerous as well. But the good news is, all of that is very treatable. All of that is very reversible. So I've kind of answered your question in a way of not saying what causes it, because actually, Sam, I don't know, frankly, but I know what might keep it going, what might maintain it, if that makes sense.
Like if you were to ask me what causes back pain, everyone would like to think that they know, but in actual fact, we have little idea, and I can imagine it's very similar. I mean, you take it, you identify all the factors that may be contributing to this state, whatever, if it is depression or back pain, and then you look at modifying those factors, and then sort of reassessing outcomes. And I can imagine, it's fairly similar. How do you go about the approach? So if you have someone who's presenting with depressive-like symptoms, you screen them, you sort of you make that working diagnosis. And then you're obviously assessing all the other things that may be contributing to that. What other sort of information are you trying to get out of that person to help sort of guide your management?
Well, I mean, the question really is, why is this person having difficulties? Why have they come to see me? And why isn't the problem going away? Because often people that come and see me, often they're trying really, really hard to, deal with the problem, depression, and but the strategies they're using that they're not working, So, sometimes people who are, perhaps quite, perfectionistic, all or nothing thinking, they keep trying harder and harder to do something using the same kind of strategies, and they don't seem to work. So what we do, we have a good look at what might be maintaining the problem. Some of the things we spoke about, ways of thinking, rumination, the way we think about ourselves, how we treat ourselves, the way we talk to ourselves. Some people are self-critical, some people withdraw from life, people avoid things, get involved in unhelpful behaviors, like drinking alcohol, for example, to excess. The mood drops, so people just say, well, I feel depressed, don't feel like doing something, so I'm not going to do it. So they put how they feel before, the action, so they don't lead their life in accordance to their values. They let their mood dictate them, which is understandable. They don't feel motivated. Then you get the physical sensations that kind of drop away. And, sometimes with managing depression, there are lots and lots of different strategies. I mean, one really effective way, actually, of managing depression, not all depressions, sometimes, is exercise. Actually, there's a lot of evidence to say that works really well.
Yeah.
So
don't speak too much about that, because we're going to do a whole podcast episode on exercise for a later edition. But absolutely, yeah.
So yeah, really, why are people having difficulties? Why isn't it going away? And our ultimate goal really is emotional change. I often say that happiness, is a byproduct of what we do. Really, we can identify what it is that's keeping us stuck. Then we can work out a treatment plan and work towards people's goals about what they want to change in their life. And so emotional change, sadness to contentment or happiness, if that's attainable, and often is, because it's something we all experience, most of us experience, and it usually is a byproduct of what we do. And if we change what we do, then we're more likely to feel that. So I don't know if that answers your question. I feel like I'm on a ramble. Am I rambling, Sam?
I don't mind your rambles at all, Colin. Yeah. I think
also that the things people bring to their lives, their rules, their assumptions about their life and how they should be and how others should be as well. We look at that as well, how they're working for them now, because it might not always be working for them. I always have to stand up for myself and be firm. Well, that's fine, but sometimes it's okay to be vulnerable.
Yeah.
Depends on the context.
Just going back to, I guess, it sort of ties into what we were talking about before with diagnosis. This is obviously, but for the most part, a condition that people will sort of present with. It's not like you fall over and break your leg and you've obviously done something bad. These are some symptoms that people experience often, unbeknownst to people around them, even those close to them, which this was one of the reasons, or the main reason, that there's so much of a focus on awareness around mental health. But obviously that's got to affect diagnosis rates as well, is that people just don't acknowledge the symptoms or don't disclose the symptoms. Would that be the case?
Yeah, I think so. It's some people don't want to show weakness. Some people don't want to sort of have a diagnosis, or to be seen as something wrong with them. And there's nothing wrong with people that have depression, but often people are trying too hard. And then my role is actually to just say, calm it down, take a step back, have a look what's happening, and let's obviously what you're doing now isn't working for you, so let's see different ways. So sometimes we'll identify some of these, what people are doing, what their thoughts are. We review, we test things out. We look for evidence to see if things are working for that person, and if not, then we see if there are other ways, and we check them out. We do things sometimes called behavioural experiments, see if we can do things differently, to see if that does make a difference. A big thing in cognitive therapy is simply activity recording. in depression. And that can be incredibly powerful, because then, you can start to identify patterns. Once you start analyzing things, you can see things that are keeping you stuck, So, we gather data as well to see what patterns are. And, we basically try and break those patterns and try and test out new ways of being. And a massive part of what I do as well in my work is relapse prevention, which is really important, because we know that people that have depression are quite likely to relapse. Usually have more than one episode. So I'm really trying to, certainly in my work, I try to, I have this thing about helping people to become their own therapist. I try and put myself out of a job. Sometimes people put me out of a job anyway. But sometimes they put me out of a job because I'm doing a good job. That's not always the case. But when we do that, that's all about relapse prevention. It's about people sort of, going off and having the tools and the skills and having that toolbox to work things out. And if they can't, it's fine. They can come back. We have, booster sessions, or whatever they're called. But relapse prevention is a big part of what I do.
Yeah. And I mean, are you able to
approach?
Yeah. Are you able to provide like an example of a strategy that you might use for relapse prevention? What are some of the things that you might sort of use with a patient?
Well, specifically for relapse prevention, relapse prevention starts from day one, really. I've always got one eye on sort of finishing and, relapse prevention. So everything we do is geared to that. And actually at the end, what I usually do, for the people I've worked with and I haven't done this, please accept my apologies. Probably means I've forgotten to. But I use something called I call it a blueprint, which is basically a document which sort of goes through, what brought you here, what was keeping the problem going, what things have been useful, what would you do in the future if things were a little bit difficult, what tools would you employ? Is there anything coming up that you need to sort of think about, sort of, skill up on, for example, what think about what people's goals are in a month, 6 months, in a year. I always use 5 years as well, because that's always a value, it's a direction that people want to head in. Nobody really knows what they're going to be doing in 5 years, but you're heading in a direction, you're living your life in accordance with your values. So that's what I do, really. And that's a document that people then take away and have, that they can then refer to as a starting point, if they need to. So that in itself is a strategy. But then one of the first things I do really is so when we talk about diagnosis, I don't really diagnose. I know it sounds like I do, but I don't really. Yeah. What I do is I look at what's keeping the problem going. I call that, it's formulation, really. So I share that with people, and we look at what's keeping the problem going, what the cycles are, we try and break those cycles. So again, that's another strategy that I use. And then once we identify what's keeping the problem going, we can develop a treatment plan to break each of those kind of cycles, really. And that then matches towards our goal. And in my work, it's always time limited. I never keep anybody in therapy for any longer than is absolutely necessary. I don't believe in it. It's not necessary. I'm always putting myself out of a job. I feel good about that most of the time, not always.
I guess just moving on, as I said at the start of the show, this week, which will be when this airs, last week on September 10th is World Suicide Prevention Day. I thought that it might be good to go into your thoughts around suicide and potential sort of links with depression.
Yeah, I mean, clearly, there are links with depression. I mean, just to say as well, I mean, today we're talking about cognitive behavioural therapy as a psychological therapy, and of course there are lots of different approaches. There are other, types of therapies as well, that people practice can be very effective. Off the top of my head, think about some of the mindfulness-based, cognitive therapy approaches, psychodynamic, interpersonal therapy, counseling for depression, also medication as well. For some people, it can be incredibly helpful. So going back to that idea of, if you break a leg or if you've got back pain or whatever, you know, you don't go and get help for it. You know, there's a lot of different options in managing depression. It's not just cognitive behavioral therapy, but it can be very, very effective for people. So, I mean, not everybody that is depressed will go on to end their life. I think it's very important, actually, to say that. In fact, a vast majority won't. I think there's a lot of hope with, you know, the treatments. I mean, certainly much more now than when I started in this field. You know, people, when they reach out, they can get very, very effective treatments. I think one of the issues with suicide, as I say, you know, depression is part of the landscape, but it doesn't explain it completely. Sometimes, you know, there is just, you know, there is a perfect storm really around it. You know, I think the first thing is that people should be prepared to have a conversation around it. You know, see people around them that are, you know, distressed. You know, to have a conversation, to be kind, compassionate, you know, to be human. You know, try and interrupt those thoughts and, you know, give people that chance to reconsider, really, because there's always hope. You know, I mean, that's why I do. You know, I wouldn't be doing this job that I do if I didn't know there was hope. And that's really, you know, a message I would give people that are having, you know, thoughts of suicide, that there is hope, and there are people that want to help. You don't have to feel trapped. You know, people often talk about, you know, being, you know, trapped or in a, you know, deep hole that, you know, sometimes they can't get out of. But there's always somebody willing, if they know, that they'll put their hand down, you know, throw something down to help you, to bring you out of that. You know, so I would say to everybody, you know, be prepared to have a conversation. You know, people being prepared to listen. Don't shy away from it. Walk towards it. I know that's tough sometimes to do. And people that feel they can't talk about it, well, actually, you can. You know, a lot of people do experience those thoughts, and I don't know, Simon, what it's a hard thing to say definitively, really. I don't feel like I'm an expert in this at all. All I know is that, you know, my experience, I always walk towards it and then walk away from it. I'd encourage people to do that. What do you think, Sam?
Yeah, absolutely. I mean, I think that acknowledgement and trying to face these sort of issues head on is the first step, and just understanding that a lot of people are struggling and are in sort of a situation. The more we talk about things, the easier we make it for everyone.
Yeah, and you know, I think it's important that people don't feel they're alone. You know, and there's a lot of support out there. I mean, there's some excellent NPO organisations. There's the English speaking one. Was it TEL? They've done a brilliant job for many, many years. You know, with their lifeline, helped an awful lot of people. And there's, you know, lots of, you know, there's the Japanese version. It's watching Denmark. You know, it's medical professionals, therapists out there. I mean, there are even digital options. You know what I mean? Things like, you know, there are apps. There's the Stay Alive app, My Happy Place, Virtual Hope Box, the Black Dog Institute. I mean, there's lots of, you know, potential resources out there. Yeah, so sometimes it's about looking, you know, asking, and
yeah, that's right. I think that when we're sort of discussing such a gloomy topic, I think that it's important to really focus on the positives and just keep reinforcing that there is help out there, and if people are struggling,
there is.
that they need to do everything they can to improve the quality of their lives, and speaking to someone and proactively seeking help is obviously the first step towards that.
Yeah, absolutely. And if if you see a friend or somebody that's struggling, don't just be human. Just reach out and be kind, awesome, how they're doing. If you think they're in a really difficult place, don't be afraid to ask them if they're even that question. Are you thinking of ending your life? Killing yourself? Don't be afraid to ask that question. You're not going to plant ideas in people's heads. Sometimes it's going to come across as a real relief to people. Shouldn't be afraid, in my opinion, to do that. But as I say, I'm not an expert. I'm just really saying what I would do really as a professional.
Yeah. Fantastic. Well, really appreciate your time as always, Colin. Do you have any other sort of last words in relation to this? Anything else that people should keep in mind?
Well, maybe just a little message, to people looking out for, risk and stuff, particularly, professionals. I would say one thing that tends to be neglected is that sort of perfectionism thing. People that think, what others expect of us. You think what others expect of us are actually what they are expecting of us, and sometimes it's not. And so sometimes people have this sort of social perfectionism, which is also a risk factor, which is often spoken about in these kind of forums. And so I would say get yourself skilled up on some of the stuff around social perfectionism, social anxiety, because it doesn't show up on the questionnaires that you might do, particularly social anxiety. So find out more about it, understand that if you are experiencing it, that there are very good treatments, and a lot of the professionals are going to go out and skill up and get some. Some of them already have, but watch out for social anxiety. I would say self-compassion, forgiveness are great antidotes to that. They're very protective to that sort of social perfectionism. But the thing is, you can get so caught up in your head with it that it's hard to, again, try too hard. And actually, sometimes you need a slightly different perspective. So I would say, talking about depression, we spoke about, suicide, but I'd also say there are other, conditions and factors. And I think sometimes that sort of social perfectionism and social anxiety also is something that, firstly, some very, very good treatments, and secondly, professionals, sure you go and get trained.
Terrific. Well, thank you very much for that, Colin, and then thanks for coming on again. And we'll make sure it's not quite so long before we get you back on in the future.
Thanks, Sam.
And yes, we'll look forward to speaking to you again soon.
Thanks, Sam. All right.
Take care.
Take care. Bye for now.